I believe that reimbursement is going to be key in how next-gen sequencing is going to be utilized. Without reimbursement, I think it will not gain widespread traction across communities, community hospitals, community oncologists. And so I think reimbursement is going to be key ultimately for that. And again, I think one of the things that's going to drive that is economies of scale and actually the cost of the underlying technology. If it gets to a certain threshold of cost, I think it will reach and be reimbursed more readily.
The turnaround times for next-generation sequencing have really been dropping. We see, for example, many of the commercial laboratories, depending on whether it's a tumor-based or a blood-based test, returning results in as short as 2 weeks or sometimes even more quickly. Obviously, the turnaround time for a tumor-based test is often limited by the ability to locate the tumor and get it to the appropriate lab. But I think what's really important is that as we have real drugs to offer patients for approved therapies in a tumor-agnostic manner, that this testing be done relatively early. So when patients initially present with a advanced or incurable cancer, that's really when I would advocate for sending this test, because if you wait for having exhausted all the standard options for that patient, you could potentially run into a problem where the test result comes back too late for the patient to benefit. And we have seen examples of that, and it's very heartbreaking when you see that happen. So when we have a patient that unfortunately develops metastatic cancer, we know that that patient is very likely to die from that cancer eventually. It seems that to maximize the chance of utility for this test, that we plan ahead a little bit and order this test before we're in a last-minute situation where 1 week could really make a difference.
Recognizing that next-generation sequencing for comprehensive assays can take a few weeks, when you sit down with a patient, it's important to recognize whether or not they're fit enough to wait for the most appropriate therapy, considering that you might find a molecular signature that's actionable in their cancer, or if you need a resort to standard of care therapy, like chemotherapy, for example, or immunotherapy, for cases where patients may be sick. And certainly in my practice and in my lung cancer clinic, I have patients who meet me that have a poor performance status, and that's mostly mediated by advanced and widely metastatic disease. If I can't get an answer of next-generation sequencing or even complementary plasma profiling or liquid biopsies, then I immediately jump to giving them chemotherapy that may hopefully turn things around. And once I get the next-generation sequencing result back or complementary plasma testing results back, assuming the patient isn't responding to therapy, I would then switch to targeted therapy or immunotherapy if appropriate. Or if they're responding well to the therapy that I instituted prior to the results of sequencing, if it ain't broke, don't fix it. Keep them on the same therapy and keep the match therapy that is based on the results of sequencing in your back pocket for when they need to switch gears and do something different.
The turnaround time is something that we use in the context of, does affect whether or not we immediately use next-gen sequencing testing. Clearly, there are some technologies like kind of hotspot mutation analysis, which can be turned around within several days, versus NGS, which can take several weeks. I think it just depends on the platform and a number of issues. I think in the community, I think, in some instances, you just can't wait several weeks for a next-gen sequencing platform to turn around. So oftentimes, I know in the community, they will order it in anticipation if a chemotherapy is not going to work, or standard chemotherapy may not work in the future, so that the patient may have alternatives later on. In my practice, which is primarily a clinical trials practice, every patient who comes into our clinic, if they do not have NGS panel, we do order an NGS panel, which is available at MD Anderson. And part of that is because it will help us identify, if not early on, but later possible actionable mutations that we can enroll patients on clinical trials.